Good evening, everyone, and welcome. My name is Catherine Winsor, and I'm the Director of Services and Evidence here at Crohn's and Colitis UK. And I'm delighted to be chairing this evening's event on food and diet. We're really lucky to be joined today by an incredible panel of speakers. We have Isabella sharing her personal experience with Crohn's disease, and we will be hearing from three experts in IBD. We have Dr. Shahida Din, a consultant gastroenterologist at Western General Hospital in Edinburgh. Her presentation will take us back to basics to explain digestion and how it's impacted by Crohn's and colitis, the impact of food on IBD, and how food choices and preferences might help or hinder. Then we have Katie Keetarut, a highly specialist IBD dietitian at University College London Hospital. Her presentation will talk about how to eat well in both remission and in a flare-up, some nutrients of concern in IBD, as well as situations where you might be advised to adapt your diet. And then we have Professor Kevin Whelan, Professor of Dietetics in the Department of Nutritional Sciences at King's College London. Kevin was an expert member of the panels developing the NICE quality standards for IBD and the ECHO guidelines for diet in IBD. He will be discussing what the research tells us about the impact of diet on IBD, including exclusive enteral nutrition, special diets, ultra-processed foods, and additives. And we're really grateful to all of them for sharing their time and expertise with all of us here tonight on this really important subject. Now, we know that it can be really difficult to understand what a diagnosis of Crohn's or colitis might mean for the way that you eat and the impact that this might have on your life more generally. More than 1,700 people have signed up for this event, which I think goes to show just how needed good quality information on diet is. Often, it's not that there's a lack of information, it's that there's just too much, and it can be hard to know what to trust. So to start us off, and to get you all involved, we'd just like to do a really quick poll to see how many of you here tonight have ever been given unsolicited advice about eating with IBD, whether that's from well-meaning friends and family or from strangers on the internet. And you should see a poll has popped up on your screen. Okay, so we can see there, look, 70% of you have been given unsolicited advice in the past about what you should be eating for your IBD. That's a lot of advice. But yet, when we asked you all whether you agreed that you had the knowledge and confidence to make decisions about the food and diet that's right for you, less than 1 in 3 of you agreed at any level. 69% of you weren't sure, disagreed, or strongly disagreed. So that, in a nutshell, is why we're here tonight. We're really hoping that this evening will help increase your knowledge and your confidence and answer some of the questions that you've shared. Now, before we get started, just a few bits of housekeeping from us. If you're joining from outside the UK, you're really welcome, but please do bear in mind that all of the information that we're giving tonight will be based on the UK healthcare system, and we aren't able to advise on options elsewhere. We'll be taking a 5-minute comfort break at about 5 to 8 to give you all a chance to stretch your legs and make a cup of tea. Given the popularity of this event, we've actually closed the public chat and the Q&A. So really important, sometimes in these events, you can be messaging us and you can be asking questions live. We've closed that for tonight because of the sheer number of people who've signed up. But you should all have been able to ask a question when you registered. And we received almost 500 questions, so I'm afraid we're not going to have the opportunity to get through them all. But we have compiled the most frequently asked questions to put to our panel at the end. So if you're having any technical issues, you can send us a message privately using the chat, but please be aware that it won't be visible to anybody else, and we're not able to give any advice on IBD through that chat. So this webinar is being recorded, and we will email you a link to the recording at the end when it's ready so that you can watch it back and share it with others. And finally, at the end of the webinar, you'll be taken to a short survey, and we'd be really grateful if you could spend a minute or two just sharing your thoughts with us on how you thought the event went so that we can improve for future. So enough of me, over to the main reason why you are all here. I'm going to introduce our first speaker. I'd like to welcome Dr. Shahida Din. Evening, Shahida, over to you.
So thank you, Catherine, for asking me to come and speak at this Crohn's and Colitis UK event. And I'm really delighted with all the participants that have joined today, and I hope that we give you information that's helpful for you. As Catherine has said, that I'll be just talking to you about the basics of gut function, the structure and anatomy, and how the gut function can be compromised in inflammatory bowel disease. And just looking at the relationship and data that we have around inflammatory bowel disease and how that influences your own choices for diet. Just to come to the basics. So this is a very simplified diagram of the gut. If you've seen me talk before, you know that I describe the gut as a long cylindrical tube that starts at your mouth and has specialized functions and goes all the way down to your bottom. And each of the part of the gut has specialized names. You've got the mouth, the food pipe, the stomach, the small bowel and the large bowel, and then the rectum and your bottom. So that's essentially the anatomy of the gut itself. And so our gut's really important in that it allows us to digest food, absorb food, and it allows us to eliminate the waste products through your bottom, and that's the feces or the stools that we often talk about. But it also has other functions, and the other functions of the gut is that it helps immune defense, so it's important as a barrier function to the gut to help protect it. It's important in hormone production, and these hormones can help also regulate our appetite, but it also has a really important function for your microbiome. And when we say microbiome, we mean the collection of bacteria or other organisms that are part of your gut and are very important. And we can see how that can be changed in inflammatory bowel disease. So what is IBD? So I think from the audience that we have today, IBD is an inflammatory bowel condition. It can affect 1 in 123 people currently in the UK. We anticipate that by the year of 2030, this will likely be nearer to 1 in 100, so it is increasing in incidence across the UK and across the world. There are main types. We have Crohn's disease, ulcerative colitis, microscopic colitis, but also IBD unclassified. And we use the term IBD unclassified usually when it refers to having inflammation in the large bowel or your colon, and it's difficult for the pathologist to tell us whether it features more like Crohn's disease or ulcerative colitis. And sometimes you might end up with one diagnosis, and over time, as the lining of the bowel changes in response to your disease or treatments that we give you, you might find that the diagnosis slightly changes. And that happens more to people who are diagnosed at a young age or young children or adults. When you have inflammatory bowel disease, I think you all have sadly experienced all these symptoms of diarrhea, constipation, fatigue, abdominal discomfort, incontinence, urgency, blood within your stool, but it also affects other parts of your body. Your joints, your skin, your eyes can also be affected. And often one of the common symptoms is actually fatigue, and that's one of the questions that we've been asked to try and help address tonight in the Q&A that comes up. With inflammatory bowel disease, it's not a static period of having bowel flare-ups. They do get better, and we call that remission. But over time, we want to try and help optimize your gut function by giving you therapy. And we're working with you to actually help you take that therapy for you. So I wanted to talk to you a little bit about how inflammation itself can actually compromise the gut function. So I've gone back to showing this very basic sort of diagram of the gut. And so I'm going to show you some cross-sectional images. That means that I've cut across the gut in somebody or somebody who's had an operation. And this is what you would normally see. So if you look at this, the blue pattern here is the actual lining of the bowel. That's what we often see when we go into somebody's bowel and we do endoscopies. The white bit here is what we call the lumens. That's the empty space or the hollow part of your gut. And these different sort of pink layers that you see are all the different layers of the bowel that you see. And that's composed of tissue, immune cells. It's also composed of muscle function. And essentially your gut is a bit like, as I say, a muscular tube that propels food forward. So if you think about how when you're trying to squeeze toothpaste out of a toothpaste tube, that's essentially what your gut does in this part of the small bowel, is it propels it forward. Now, when you have inflammatory bowel disease, and the next section I'm going to show you is somebody who's had an operation to remove some part of the small bowel, this is what happens, is that you have the inside of the bowel becomes really narrowed, and the lining of the bowel can come away. Now, a little bit of this will be the artifact that happens when you process these samples, but that's what can happen here. And then you might notice that it's very striking that the layering of the bowel actually becomes really thick-walled here. And that's because you have a huge number of immune cells that come in, the tissue swells, the muscles actually become bigger, and you also have more muscle cells here. So you go from having a very flexible tube that propels food forward to actually having a very stiff tube that can't propel food forward very well, but also that the inside of the bowel itself becomes very constricted. And so trying to push the food through this area, as you can imagine, might be really difficult. And that reflects some of the symptoms that you might experience. So you might experience abdominal discomfort. You might start experiencing cramps because the bowel's really trying to push hard, what's inside of that. And that's some of the things that when we ask you, we're trying to work out how the gut is actually affected in you. So this is a picture of just a very, again, simplified diagram of the gut. And what I've shown you here is if you look at here, this bit here in a bit more detail, and I'll orientate you a little bit. So this bit here is the actual the lumen part of the gut, which we call here, is up here. And then before you actually get to the cells of the lining of the bowel, there's this layer of mucus that's really important. And the reason it's important is actually it has a number of functions. It actually helps protect the gut. So you can imagine having food products here. It tries to help digest the food before it actually reaches the cells down here. And inflammatory bowel disease is not just one condition, although we call it Crohn's disease or ulcerative colitis or IBD. It's actually a range of conditions within that. There's a huge spectrum of disease. And that's why when we see patients will often tell us that actually their symptoms are really individual to them. Some people will have mostly abdominal pain. Some patients may just have diarrhea or bleeding. And so it really depends on which part of the gut's affected and how that inflammation can actually affect your bowel. So for example, we know that there's some changes in the lining of this mucus layer here that can actually precipitate inflammatory bowel disease. We know that these cells, how they're nicely packed here, they can actually become loosened and you end up getting really gaps in here where food products can go through. And when the cells of your gut actually start to seep food particles in an unusual way, in that it's not been digested properly or it's been injured in some way, it starts up a reaction and you get an immune reaction that happens that leads to the production of inflammation that goes into overdrive. So this is the small bowel. I wanted to show you a similar image that you can have in the large bowel. And this is an ultrasound of some patients. And again, I'll just orientate you a little bit. So here is the outside. Here is the abdominal muscle wall layer. Here is the kind of abdominal fat or tissue that you might see. And this is the lining of the bowel here, just between these two white dots here. So that signifies the lining of the bowel. And the lining of the bowel, when it's normal, it's actually not thick at all. It's about 3 millimeters maximum. And this is the other parts of the gut here. Now, when you have inflammation in the colon, what happens here is that all these dots tell us that there's lots more blood supply and the lining of the bowel becomes really thickened. So just as I've shown in you other picture of the small bowel, if the lining becomes thickened, it becomes stiff. It then can't actually work as a muscle tube to try and propel food forward. Because it's thickened, you can imagine that trying nutrients or food particles that have been digested, trying to go through that thickened bowel, it's actually really difficult. So as well as getting symptoms of abdominal discomfort and cramping, you will get symptoms of diarrhea because you're not able to reabsorb food or not able to reabsorb the food particles in that process. And that will lead to some of the other symptoms that you might be experiencing. So that's just to show you that when you have inflammation, it has a number of effects on the gut itself. It's not just the fact that the bowel is ulcerated that it gives you all these symptoms, it's the fact that it's changes in the lining of the bowel compromise its function, which then feed into the symptoms that you experience. So IBD can lead to compromised gut function. This is just a summary to show you that. So for example, when we talked about digestion, if you have a sore mouth, if you have mouth ulcers, if you're lacking in some of the enzymes because the mouth is dry, you're not going to be able to break down the food very well, and you're not going to be able to mix it very well. Your stomach is essentially a muscle bag in which the food that goes in there, there's lots of sort of protein molecules or enzymes that are produced to help break down the food. But it has a mechanical function like a food mixer. It mixes the food up to allow it to be broken down so it can be absorbed. So that leads to impaired breakdown of your food. So you might imagine that somebody might eat food and actually because it's not broken down so well, you actually get really bloated and feel uncomfortable and sore. If the lining of the bowel is swollen, ulcerated or damaged, that can lead to poor absorption of the nutrients themselves because they can't get through that thick lining. When they do actually come through, the body thinks there's something unusual going on and starts to mount an even more exaggerated immune response because it feels it needs to protect itself. And that leads to a lack of calories or nutrient deficiencies. And the large bowel, which is the colon, which we talked about, one of the main functions of the large bowel is to actually reabsorb salts and fluid. And if it can't do that, you will end up with symptoms of diarrhea, needing to go to a toilet in a very urgent manner, bleeding in the bowel motions, and sadly for some patients, having incontinence, and that then obviously giving them a huge burden of symptoms. Remember that I said that there was other things that the gut does too. So hormonal regulations, you can lead to a loss of cells that regulate hormones, and that means it can disrupt your appetite, it can disrupt the signals that you experience with the actual symptoms, with pain and discomfort. The mucus barrier, which we spoke about, that's really important to try and protect the lining of the bowel cells. And so if that's disrupted and the cells are now being exposed to things that they wouldn't necessarily see, that sets up inflammation, so it can make you more prone to infections. The microbiome, so the number of bacteria that you have or viruses that we believe you also do have in that area, when that's disrupted, you can get other symptoms. It can give you bloating and abdominal discomfort again, and diarrhea. And remember when I said that inflammatory bowel disease doesn't just affect the gut itself, it does affect other organs. So if you have active inflammation, we do believe that some of those active inflammatory cells in the gut probably do travel through your bloodstream into other parts, so like your eyes, your skin, your joints, and your muscles and your blood vessels. And that's why a lot of our patients will say that they have other symptoms too. And sometimes some patients don't necessarily have gut symptoms. They just, for example, will have mouth ulcers that are very prominent, and that leads to the diagnosis. So they might have lots of red eyes or bloodshot eyes, or they might get skin rashes that are then lead to the diagnosis of inflammatory bowel disease. So there's a range of sort of symptoms that patients can experience, and signs that we can see when we do these investigations that tell us that the gut is compromised. So now I'm going to move on just to talk about, how does IBD develop and where does food fit into that? So IBD develops in people who have certain gene changes that predispose to the development of inflammatory bowel disease. We know a little bit about these changes because it can affect essentially any part of your gut. It can affect the microbiome composition, it can affect the mucus layer, it can affect how tightly these cells are packed together, it can affect your response to injury. And just one thing to remember is that the lining of the gut renews itself every 3 to 5 days in everybody. And I know that if I have a very heavy meal with very rich foods, that I'm going to get some symptoms too. And I guess the difference between myself, who doesn't have IBD, and yourselves is that my bowel can regulate itself. So although it may set up a little bit of inflammation if I've eaten something different or I've had infection or gastroenteritis, my gut will settle itself down. What happens in IBD is that you have a triggering event that results in gut inflammation. This is what we really believe, and we see that in some cases, in that some patients will say to us, I've actually eaten something different, it's upset my gut, and I just can't seem to get better now. And we do see that as a route to some people who are getting diagnosed. The gut inflammation, as I've mentioned, remains in overdrive. It can't reset itself back down, because gut inflammation is actually a protective mechanism for us. It's important to allow our gut to heal. But when it's in overdrive, it causes tissue damage. And that's the ulcers that we see when we do your endoscopy procedures. And there are some diets that are high in ultra-processed foods, sugar and fats, and low in fiber, that are associated with changes in your gut permeability. So what I mean by that is how easy it is for other food particles or other just particles or by microbiome organisms to actually be able to get through the lining of the gut. It leads to changes in gut microbiome, and we've seen that in different studies. These may activate immune responses in some patients, and in countries now that we're seeing who have adopted a very westernized diet with quite a lot of ultra-processed food, that seems to be associated with an increased incidence of inflammatory bowel disease. Now, a lot of these studies that we talk about are studies where we've associated the changes. So essentially, we've either had a group of patients that we follow up, and if they develop IBD, we then look back to see why that is in their history, or you have a patient or group of patients who have IBD or inflammatory bowel disease, and you look back to see in their history and try and work out why that is. There's no real direct evidence that food actually causes IBD at the minute, but there is, as I say, these association studies that it is associated with different sort of dietary patterns that people have. So that's as best, I'm afraid, that we have can food cause IBD. That's as good as the evidence is at the minute. Can food reduce the risk of inflammatory bowel disease? And we are really interested in this topic, and that's because food is something that is really universal. So if we've seen an association of certain foods, is there certain foods or diets that can reduce your risk over time? So this is what the data at the minute shows. And remember what I've said, that these are association studies. These are not direct studies. So it's not as if you're giving one group of people a different diet and another group of people a different diet and then following up what's happening. This is going from what people tell us from their history. So some of the new data that's coming now is showing us that early life exposure to fish and vegetables in the first year of life reduces the risk of inflammatory bowel disease. The Mediterranean diet, which is rich in fruits, vegetables, whole grains, legumes, nuts, olive oil, and fish, seems to be associated with a reduction in Crohn's disease. The cardioprotective diet, which is actually really similar to the Mediterranean diet, seems to be associated with a lower risk of inflammatory bowel disease. And in population-based studies of food habits, if you've adopted a mostly plant-based diet, that seems to be associated with a reduced risk of future inflammatory bowel disease, both ulcerative colitis and Crohn's disease. And it's interesting when they talk about processing of plant foods, because if you process plant foods, interestingly, they are associated with an increased risk of Crohn's disease. And so that tells us that the processing that's done to food might somehow influence how your gut responds to the food that you eat. And then does that set up a different reaction in patients who are likely to develop inflammatory bowel disease? And that's what the triggering event might be. And that's how good the data is about whether food can reduce the risk of IBD. If we go on to the next topic, can food trigger a flare-up of IBD? And this is a difficult study to actually do because we all have very individual responses to food. And that's because everybody really is very individual. Your gut composition, the microbiome composition, how your gut functions is really very unique to you. And we haven't quite got to that stage where we can actually produce a fingerprint of what somebody's gut function looks like. But I am really grateful for all the research studies that are being done, and all really very obviously humbled by all the patients who come forward and give us these extra tissue samples to try and help understand this. But for now, we know that certain types of food can actually upset your stomach or your gut and give you symptoms. So some people find that high fiber foods such as raw vegetables, nuts and seeds, or corn can actually be difficult to digest when they're not feeling well. Similar can happen with fatty, greasy foods or with dairy-containing foods or lactose-containing foods. And it can also happen with spicy foods, caffeine, alcohol, and artificial sweeteners. They can all give you very different symptoms. And if I eat any of these in high quantity or high abundance, I think I would get some symptoms too. But remember what I said, that in my gut, it will be able to reset itself. But somebody with inflammatory bowel disease whose gut might be inflamed, trying any of these foods, they might find a bit difficult to actually take. If you want to try and study whether food actually triggers a flare of inflammatory bowel disease, the best way to do this, we think, is to actually study people who have in remission, so that actually the disease is very well controlled. And my colleague who works with me in Edinburgh, Professor Charlie Lees, has actually done such a study. He's actually recruited patients to his study where they've been in remission, so where disease has been very good control, and then look to see what other associations might lead to a flare-up. And there's some really interesting data coming from that regarding different types of food and how that might be associated with a flare in either ulcerative colitis or Crohn's disease. And so not to give you any information at the minute, but that information is coming and hopefully will be available for you to be able to use, hopefully, or influence your own dietary eating patterns in the next few months and years. So can food treat IBD? So I will touch on this briefly, but Professor Whelan, who we'll hear from talking last, will be able to give us a little bit more extra information about this. So some diets have definitely been studied in people during flare-up and active disease. Some of you may be familiar with an elemental diet, so that's something like modulin. And you might be familiar with a polymeric diet, which is replacing your diet with nutritionally complete supplements such as Ensure and Fortisip that are composed of essentially the nutrients, protein, carbohydrates, and fats. There are other diets that they try and use real food. So food exclusion diets are diets that are usually based on real food that you can eat, but it's just that they restrict the different types of food that you might be able to eat. And there's a number of these that have been studied, some of us, I say, which you will hear later on. So I'll not dwell too much on that. But this is, again, an area of real interest to us, and I think to patients too, is that how can we try and help support, a diet that would keep people well and in remission and actually be able to treat your disease long term. So the other thing I'm going to talk about is just individual dietary preferences. And when you have an individual dietary preference where you might restrict certain food or food groups, the risk here is that that dietary preference can impact on your calorie and nutrient intake. So if you are going to follow a specific diet and you have inflammatory bowel disease, whether you're in remission or you're having a flare, it's quite important to be able to actually talk to a dietitian to work out whether this is, following the diet that you want to follow would actually be good for you at that time. Interestingly, iron and vitamin D deficiencies are very common in the general population. If you sampled everybody on this call today, including people who don't have inflammatory bowel disease, iron and vitamin D deficiencies affect up to 50% of our population. And in Scotland, vitamin D deficiency affects nearly everybody because we don't have as much sunlight as other parts of the UK. So that's very common anyway in the general population. Vitamin B12 deficiency is really important if you just follow a vegetarian or vegan diet, and that's because vitamin B12 we can only actually get from animal sources. Now, there are some products such as bread and cereals that are fortified with vitamin B12. So if you are going to follow a vegetarian vegan diet, I would really encourage you to talk to either your GP or your GI team to actually have your vitamin D levels taken. And in the unit that I work in, we actually try and offer everybody an annual iron level, B12 level, folic acid level, and vitamin D level to be able to sort of preempt whether somebody has deficiency. And as I say, the most common deficiencies that I see are iron and folic acid and vitamin D and vitamin B12 if they follow a mainly vegetarian diet. Remember, you can also get vitamin B12 deficiency if you've had part of your small bowel called the terminal ileum removed, because the terminal ileum is the area of the bowel that you absorb vitamin B12. So if you have had an operation and that part of the bowel has been removed, or you have an ileostomy or a stone from the small bowel, it is likely that you will become vitamin B12 deficient in the future if you aren't already. And so you should be being offered vitamin B12 injections. So please do check in, as I say, with your GP or your GI teams for that. So just to say about fasting is that some people like to fast for lots of different reasons, both religious or personal, or monitoring their weight. Fasting obviously can worsen your existing calorie and nutrient deficiencies if you have those. And so if you want to fast, I normally advise patients that they do it when they're stable in remission and they have good nutrition status. And there's certain situations where I would be cautious about fasting, and that's when you have active disease, if you have strictures or bowel obstruction is happening, if you're underweight, if you had surgery, if you're very young and you're still growing, if you're on steroid therapy, or you have other nutritional deficiencies, it would be, I would advise caution in that area. But again, it's something to discuss with your GI team. But I'll just briefly mention this. Fibre is really important, and it's important because it's part of plant foods, and your body won't be able to digest or absorb most fibre that we take in. Fibre tends to pass through our gut intact, and while, as I say, we can't digest or absorb it, it is important, we believe, for immune and microbiome function going forward. Dietary fibres in two different forms. You have soluble fibre, which is the soft part of the inside of a fruit or a vegetable that you might find, and then you have the insoluble part, which is a very hardy bit, which the hard vegetables that you might find. The soft part called soluble fibre is the part that can be fermented in the large bowel called the colon, and that can lead to symptoms in some patients. As I say, it does have lots of roles within your gut. It helps regulate how quickly the gut empties. And these are some of the examples that you might see of fibre in your own dietary. I think I get quite sad when I hear that patients often just don't eat fibre at all. And I think we do have to be a little bit better from the healthcare professionals to actually give you better advice, focus on fibre than what you may or may not manage. And I guess one of the things I like to talk about is trying to eat food close to its natural form. And this is just to give you an example of what I mean by that. Is that minimally processed food is food that actually looks like what you might expect it to be in its natural form. So for example, if you look at the top line, you've got fresh or frozen fish. If food is canned, so if canned fish or canned vegetables, that's a little bit processed. If you then go on to make breaded fish sticks or corn chips or other things like that, they are becoming more processed in that time. And so it is helpful to think about that. As I said, I've shown you data to suggest that a very high processed diets can increase the risk of developing IBD in the future. And so often I say to patients is that, try and pick processed foods that have a low amount of fat added and salt and sugar. Get into the habit of trying to read food labels and think about how you might be able to cook at home, make your own snacks and healthy alternatives. And that is something that I even would say to my children, is that, if you're reading a food label and there's lots of ingredients that you actually don't understand what they mean, it will tell you that you've got lots of additives in there and the food's highly processed. So that's just something, a takeaway to take with you. I did just want to touch upon food poverty and insecurity. It's all well me being sitting here and saying that you need to eat X, Y, and Z, but actually, if you can't afford the food that I'm talking about, that does actually lead to a lot of anxiety in patients about how they might manage that. And there is some data to show that, when you're in food poverty or food insecurity, it's linked to anxiety, depression, and stress. And obviously that can then worsen the symptoms that you have. And that's where I think, from a healthcare professional, we need to be better at helping you, signposting you to foods such as, for example, frozen food, meat, vegetables, and fish, because they're frozen usually quite quickly after they've been harvested, or if they've been culled, then they do actually retain a lot of the nutrients, and often frozen food is much cheaper than the fresh ones that you might buy. So I think some of the things that we need to try and focus on in the short-term future is access to dietitians, thinking about food poverty, thinking about the nutrient deficiencies that people have and providing supplements where necessary, but also thinking about how we might support patients to have a budget-friendly meal plan. So I hope that's been helpful, and thank you for joining us today. And I'll hand back to Catherine, and I am really sorry if I've overrun a little bit.
That's lovely. Thank you, Shahida. Lots of hearts, lots of love, lots of thumbs up coming on the screen there. So clearly everybody was really enjoying that. Thank you. Apologies that I know a few people have been struggling with the volume a little bit. So just to reassure everybody, you will get a recording of the webinar afterwards, and you'll be able to watch it back at your leisure. So hopefully you've been able to sort the problems out. I can see in the chat the team have been telling people how to try and troubleshoot. So hopefully those problems have been resolved. Right, so I'm now going to move us on to our second speaker of the evening, and I'm delighted to introduce you all to Isabella. So Isabella is here to tell us her personal story about her experience with Crohn's disease. Welcome, Izzy.
Thank you. So hi, I'm Izzy. In my day job, I work as a social researcher within the civil service, and I'm currently in the Department for Business and Trade. But I'm here this evening to provide a patient perspective as an IBD patient myself. So I'll start by sharing a little bit about myself, followed by my experiences of diet and nutrition. I'll talk about my dietitian and my wider IBD team, and then also finish with some final remarks. So a little background on me. I was diagnosed with Crohn's disease in the summer of 2018, and I'm currently treated at University College London Hospital, or UCLH, from which I've had a really positive experience. I reached remission in April 2024, the years prior to which were a real struggle for me, and I've been through lots of different dietary changes within that time. So just to stress that when I talk through my experiences of diet and nutrition, that these are my personal experiences, and it's not, and it's always best to listen to your own medical team, as what worked for me might not work for you. So what experiences of diet and nutrition have I had? Within the last 7 years of having Crohn's disease, I've had a prescribed elemental modular liquid diet from my hospital twice, which is a pretty drastic change from a normal solid diet. And for each of these, it was approximately 3 months duration that I had to be on these liquid drinks. Although currently at the moment, I'm in remission and I'm eating a solid and balanced diet. So in my experience of going on the liquid drinks, they had a massively positive impact on my bowel movements, which returned to an almost pre-Crohn's state within a month of being on the drinks themselves. The first time I went on them, I was having to come off my normal Crohn's immunosuppressants. So whilst I found that the drinks really did help the bowel movement side of everything, my other symptoms, like, as we all know, joint pain, fatigue, they didn't so much help with that. It was more the digestive sort of system pains that were really massively helped by that. The second time I was put on the liquid drinks was because my medication had stopped working, which we didn't know at the time, and it was going through all those tests and sort of figuring out what was happening there. And I had a very similar experience to the first time. So there were lots of positives in my digestion, but then all those other Crohn's pains were persisting alongside it. It was very challenging to only be on the prescribed liquid drinks, as they were all quite sweet flavored. But I worked with my dietitian, Katie, to get a variety of the flavors that were available. And I think a big motivator for me was the reduction in digestive pain. So that sort of kept me going through all the cravings that I had for solid food. Transitioning off the liquid drinks, I had a very plain, almost baby food type meals. So I was having a lot of homemade soups and things like that. And it was very gradual. So I started with 1 non-liquid meal, and then I moved on to 2 and so on. And then gradually over time as well, I moved the food to be less soft and more varied as well. So diet is very personal, and at different stages of my disease, I've had very different diets. So now I'm in remission. My main restrictions are just some types of fruit and vegetable, having nothing raw, no red meats, and also some limited cheese. But just to shed some light, I can tolerate gluten. I also have the occasional cake or ice cream, and I can even have roast dinners now, which would have been unthinkable at other times throughout my disease. So for me right now, it's all about moderation. So since being in remission, I do have treats every so often, but I do try to time it so that it's not before a big life event or a work deadline. So for me, often Fridays is the best time to sort of try something. So I have the whole weekend to recover should I have a bad reaction to that. I often try and have things at home as well if possible, because I find then it's just somewhere I'm a bit more comfortable if I'm trying a new food. And also I try and have it in a small quantity to see if there's a reaction. If there's none, then I slowly increase it over time. So a message I often give myself and that I really wanted to share with you all is that you can only ever do your best with the information you have. So do not feel bad if you make any mistakes with your diet. So for example, it took me a year to realize that maize starch is just corn, which was actually making my symptoms worse. So I've mentioned my dietitian, Katie. She's been an absolutely huge help and support through my sort of liquid diet that I was on. But I should also say that she supported me with my diet at all stages of my Crohn's disease. In terms of my medical team, there are 3 relationships I have. So firstly, the doctors, who I speak to every 3 to 6 months, depending on how active my disease is. Secondly, there's my nurse, who I email any immediate queries that cannot wait. So for example, if I get a new rash or if my symptoms worsen. And lastly, my amazing dietitian, Katie, for all my food related queries. So Katie's helped me with easing on and off the liquid drinks in a gradual way. She's advised me on everyday meals, and sort of looking at those solid foods as well. So in our last call, Katie and I were looking at safe ways to add more variety into my diet. So to give you an example, I tolerate broccoli quite well at the moment. So now I'm trying purple sprouting broccoli next, and it's going well so far. I feel very lucky to have such an engaged team around me, and I make sure not to make any major changes on my own without talking to my team first. So to provide some closing remarks, my diet is currently all about balance. I eat a low-fat diet. So for me, that means limiting cheese and also anything with cocoa in, as that seems to give me an upset stomach. But I still will have a slice of chocolate cake every so often, and I am fine with that. When I was really unwell, a very restricted diet is all that worked to stop my pain. So also to say, don't be afraid to push for what works for you, even if it's turning down going out to restaurants or having takeaways. And if you are even finding that when you have a very restricted, very clean, Crohn's friendly diet that you're still in pain, then liquid drinks may be a possibility to discuss with your medical team, as they can really help to reset your digestive system. When you're well, try not to be afraid to try all the new foods and try not to associate them with the pain, because I think that's quite a difficult thing to unlearn. And diet is one of the tools we have, but there are sometimes other factors like your stress levels that could affect your symptoms. So make sure if you have any new foods in small quantities that you try them more than once. Just make sure it's the food and not something else that might be going on behind the scenes. And lastly, just to say, something I'm really passionate about is improving the lives of individuals with Crohn's and colitis. And I've often thought perhaps an app that we can scan items in the supermarket, see ingredients clearly, but also get suggestions if it's IBD friendly, and you could customize that to your personal allergies and intolerances is a really useful tool. So I'm just sort of understanding the market for that at the moment. I know there's some apps already in development around emulsifiers, but if there's, if this is a new thing, then it's something I'm hoping to develop. So hopefully keep your eyes peeled for something like that. Thank you so much for listening. I'll now hand back to Catherine.
Izzy, thank you. The hearts and the applause and everything else speaks for itself. But thank you so much for sharing your story. I personally was delighted to hear that chocolate cake is on your list, and purple sprouting broccoli. I mean, that's like, do let us know how that goes. But no, it's so insightful and so good to kind of be able to balance what Shahida was talking about, the science and the medical side of things, with actually a real life lived experience story and the reality of it. So thank you so much.
Thank you.
Now, lots of people were asking during that about how you get access to a dietitian, and whether or not Izzy's was part of her NHS treatment, and people saying I've not been offered that myself. So I'm hoping that our next speaker, Katie, will be able to cover some of that in her slides. I'm delighted to introduce everybody to Katie. over to you.
Hi, thanks for that lovely introduction, and thanks so much, Isabel, for talking. Really enjoyed hearing what you had to say, and I'm really pleased and happy that you're now able to manage such a varied diet. So yeah, just really, really happy for you. So that's great. Thanks so much for offering to speak today as well. So my name is Katie. So I'm a dietitian. I work at University College London Hospital. So today my talk is going to be quite practical based. So how you may want to modify your diet during remission or during a flare-up, depending on what your symptoms are, and hopefully I can give you some practical advice which you can implement. So I'm just going to share my slides. So I know we're running a bit behind, so I'll run through as quickly as I can. So what am I going to cover today? So basically I'm going to be looking at how to eat well with inflammatory bowel disease. So how you may want to adapt that during a flare-up and during remission. I'll be touching on the main nutrients of concern in inflammatory bowel disease. I know they have already been discussed a little bit, but I'll discuss those in a bit more detail. And then I'll go on to talk about the situations where you may want to adapt your diet, so maybe different disease states or post-surgery or in an active flare-up. I think there's been a lot of questions about when is useful to use a food diary, so I thought I'd also touch on that. And then I'll talk about use of supplements, and there's some information at the end, so useful websites and resources where you can get further information. So I'm sure a lot of you have seen this before. So this is our Eat Well guide, which is available on the NHS website. So this is the general health eating guide for the general population. However, we do still recommend following general health eating guidelines as well in inflammatory bowel disease. So I thought it was important to highlight that and emphasize that general health eating still applies to people with inflammatory bowel disease. So what the Eat Well guide is, it's basically looking at the proportion you should be aiming for from each of the food groups. So as you can see from this plate, a third should be coming from your starchy carbohydrate foods, a third should be coming from fruit and vegetables, and then a smaller proportion from your protein-rich foods and dairy foods. And fat and snacks, cakes, biscuits, etc. should form the smallest part of your diet, so they're actually excluded from the main plate. So in inflammatory bowel disease, there is some evidence that following a slightly modified version of the Eat Well guide, in line with what we call the Mediterranean style way of eating, may actually be slightly more beneficial. So there's some evidence to suggest, especially in ulcerative colitis, that people in studies that have followed the Mediterranean diet have actually stayed in remission longer, have flared up less frequently, and have had a reduction in inflammatory markers. We have also found that in Crohn's disease, but it hasn't reached the same sort of statistical significance. However, there are also additional benefits to being on a Mediterranean diet in terms of reducing the risk of cardiovascular disease, reducing the risk of certain cancers. There's a lot of health benefits of following this pattern of eating, including improving your gut health. Your gut health. So the diet is based around quite a high fiber diet. So I would emphasize we recommend this diet if tolerated, and it may need to be modified on an individual basis. But the guide around the Mediterranean diet is to try and have a diet with plenty of plant-based foods, lots of fruits and vegetables, seeds and nuts, aiming for whole grains on a daily basis if possible, including dairy foods daily for calcium, and including at least 2 portions of fish per week, one of which should be oily. So by oily fish, what we mean is fishes including salmon, mackerel, pilchard, sardines, or trout. So these particular type of fish are high in what we call omega-3 fatty acids, which we know are anti-inflammatory. And in studies looking at the development of people with inflammatory bowel disease, again, especially in patients with ulcerative colitis, they found it had a significant protective factor in developing ulcerative colitis. Whereas there's some evidence that having a high intake of red or processed meat may increase the incidence of inflammatory bowel disease. Also, having a lot of red and processed meat can increase the risk of bowel cancer. So we do recommend, it's still beneficial to include red meat in the diet, but we would recommend having it as a lower proportion of your protein intake because of those additional risks. When it comes to fats and oils, the Mediterranean diet recommends aiming to mainly use olive oil as your main source of fat in cooking. We would recommend limiting or avoiding fats such as vegetable oil, which are thought to not be as beneficial in inflammatory bowel disease, and some research actually suggests it might be pro-inflammatory. So that's the basis around the Mediterranean diet. So we would recommend having a diverse diet, high in fruits, vegetables, nuts and pulses to support beneficial gut microbiota or gut health. And as I mentioned, it would link to long-term better outcomes, so also reducing the risk of other conditions such as cardiovascular disease and cancer. So fibre is a question we get asked about a lot in inflammatory bowel disease. Unfortunately, I think a lot of people get informed when they're diagnosed that fibre should be excluded from the diet. There's a little bit of confusion and misinformation around fibre. So fibre, there is no evidence anywhere that fibre promotes or causes gut inflammation. The only reason we recommend avoiding or limiting fibre in a flare-up or when you're newly diagnosed is because of the physical effect that it has on the gut. So if you have a lot of what we call bulking fibre, it can potentially stimulate the bowel more. If you're already feeling in a lot of pain or having a lot of loose stools, it could stimulate the bowel more, so aggravate the symptoms. So that is the only reason we recommend limiting fibre in an acute flare-up or in newly diagnosed people with inflammatory bowel disease. The only long-term situation where we would recommend limiting fibre is if you have a complication called stricturing disease, which is found in Crohn's disease, when scar tissue can form around the lining of the gut, which can narrow the lumen of the gut. And there is a slight risk of blockage if you have a lot of fibre. So that is the main and really only indication of completely or severely limiting your intake of fibre. The government recommendation for the general population is 25 to 30 grams a day, which it is quite high in the general population. The majority of people don't actually reach this, but that is still the guidelines even for people with inflammatory bowel disease. So they're a bit text heavy, but I just wanted to give you as much information as possible. So I'm just going to go into a little bit more detail about some of the food groups. So protein-rich food is very important. So this is the main sort of source of iron, B12, zinc, folate. So some of the nutrients that are very important in people with inflammatory bowel disease, because those all specific nutrients also are the highest nutrients of concern as well. So protein-rich foods help to repair tissues. So they're very important if you've had surgery. So your protein requirements might be slightly higher after an operation, or if you're in an active flare-up, also your energy and protein requirements will be slightly higher. So it's very important to try and continue to eat foods from this food group. In line with the Mediterranean diet, we may recommend increasing your intake of more plant-based proteins if these are tolerated. So things like tofu, lentils, pulses where tolerated. Foods like chicken, turkey, fish are generally all quite easy to digest in active disease or in remission. So generally those kinds of protein-rich foods should be tolerated by most people with the condition. So I've just put a top tip there in terms of a flare-up. So if you were finding you were struggling to digest protein, we would generally recommend going for the lighter meats. So chicken, breast, turkey, eggs tend to do quite well, and easy to digest. If you wanted to have some of the more iron-rich meats, we often recommend using a slow cooker. So if you cook the meat for a long time, it texturizes it and it's easy to digest. When it comes to beef, we'd recommend going for the most leanest source, so the 5% fat. I've already mentioned about red and processed meat, so it's still beneficial to include red meat in the diet because it's a very good source of iron. We just recommend keeping it to sort of the restrictions recommended. So fruit and vegetables is another food group which a lot of people really do struggle with. Some people struggle with it, throughout their disease course. Other patients I've seen in the hospital only really struggle with it in an acute flare-up. If you are able to tolerate fruit and vegetables and your symptoms are stable, we'd recommend trying to consume the largest variety of fruit and vegetables as possible. So them you're having mixture, having good variety is really the key. I've listed out a few specific types of fruits and vegetables which may be more beneficial for gut health, so maybe slightly higher in antioxidants or have sort of a natural, what we call prebiotic property. So what we mean by prebiotic property is foods which may stimulate the beneficial growth of good bacteria within the gut. So those types of foods would include foods such as artichoke, red onion, spinach, broccoli, asparagus, leeks, garlic, bananas. Also fermented foods such as sauerkraut and kimchi can also be beneficial for gut health if you can tolerate them. During a flare-up, we still recommend trying to consume a good variety of fruit and vegetables, but you may need to really look at texture modification. So rather than completely avoiding fruit and vegetables, we'd say, is there any way you can modify that fruit or vegetable to make it easier to digest? So one option is to peel the skin off. The other one is to cook it really well. So what I usually recommend with vegetables is if you can mash it with a fork, then it should be easy to digest. Often root vegetables are easier to digest, such as carrots, butternut squash, sweet potato, swede. So things that are easy to cook and mash or blend. So soups can be really useful as well. So if you can liquidize or blend the vegetables, then that's a good way of still retaining, you know, some nutrients in your diet, but having it in a much more easily digestible form. I've listed some fruit and vegetables at the very bottom of the screen that are low in sort of bulking fibre, but also low in what we call fermentable carbohydrate. So fermentable carbohydrate I'll be touching on a later slide, but this is a particular type of carbohydrate which can also cause gut symptoms, can cause gas, bloating, wind, and some of them can have a laxative effect. So these particular fruit and vegetables at the bottom are low in fibre, but also low in fermentable carbohydrate. So they should be very easy to digest in a flare-up. So starchy food is the next group. So this should form a third of your, so on the plate, this is a third of your intake through the day. So this is the main energy source of the diet. So it is important, if you can, to try and include these foods within your diet. So the main starchy foods are bread, pasta, cereal, rice, potatoes. During remission, we would say to try and go for the higher fibre options, or what we call whole grain options. So that would be going for like wholemeal bread, wholemeal pasta, whole oats or brown rice. However, in a flare-up, you may find that those kinds of foods are a bit harder to digest. So temporarily during a flare-up, you might find going for like white cooked rice is better, having cooked mashed potatoes or taking the skins off, using things like rice noodles. Also, some people find limiting gluten during a flare-up can be useful. That's mainly, again, because it can stimulate the bowel more. So you may want to try using rice-based pasta or gluten-free bread, or using sourdough bread or sourdough spelt bread. So sourdough bread isn't specifically gluten-free, but it's low in a specific carbohydrate called fructans, which can stimulate the bowel. So sometimes switching to that during the flare-up can be quite helpful. So these are the main nutrients of concern in inflammatory bowel disease. So I think some of these have been touched on in the previous presentation, but I just wanted to re-emphasize about vitamin B12. So vitamin B12 in people who've had surgery, so if you've had the end of the small bowel removed, which is very common in Crohn's disease, the terminal ileum, your ability to absorb B12 it will be very low. So I'd recommend if any of you've had surgery that you do get your vitamin B12 level checked, and you may require supplements or injections, so either tablets or injections. The other group where vitamin B12 is definitely a nutrient of concern is people on a vegan diet. So if you don't have any animal-based foods, then you would not be able to get enough B12 through your diet. So you would need to take a supplement. One useful supplement you can use in a vegan diet are the you can get nutritional yeast flakes. So you can sprinkle those on food, and 1 to 2 tablespoons a day would give you your daily requirement of B12. So that's quite an easy way of getting enough B12 if you wanted to do it more naturally through diet, or you would need to take a supplement if not. Iron and calcium I'm going to discuss on the next slides. Folate. So there's a couple of medications that can inhibit folic acid absorption. So if you're on methotrexate or sulfasalazine, you would need to take a folic acid supplement. So again, any of you that may be on those medications, that's something you would need to speak with the IBD team about. Folic acid is found, or folate is found naturally in mainly dark green leafy vegetables, so things like kale, spinach. It's found in broccoli, Brussels sprouts. So again, some people who aren't able to tolerate very fibrous vegetables may be at higher risk of folate deficiency, so that's something to be aware of. Vitamin D, I think, was already mentioned in the previous presentation, so I'll push through that. So iron is one of the most common nutrients of concern in inflammatory bowel disease. The reason for that is either a lack of iron in the diet. So again, if you're on a vegan or vegetarian diet, it can be very common in an acute flare-up. So if you have blood loss in the stool, then that will put you at high risk of iron deficiency. So the main sort of readily absorbable forms of iron are from meat products. So beef, chicken, turkey, lamb. You can also get it in things like lentils or beans. Fortified breakfast cereals are a good source as well. Other good sources of iron are actually shellfish. So in oysters and mussels, if you're preferring to get it less from red meat, you can also increase your intake of shellfish, and that will be another good way of getting iron. Also some seeds, so pumpkin seeds, sunflower seeds, flax seeds also contain iron. If you're wanting to increase your intake of iron through plant-based foods, we would recommend having something high in vitamin C with your meal, and that aids iron absorption. So that could be a small glass of fruit juice, or having some vegetables high in iron, such as broccoli or peppers or something like that, or just a glass of juice like Ribena. Tea and coffee can inhibit iron absorption, so I'd recommend to have a drink tea or coffee with your food. Always wait 30 minutes to an hour. And calcium is the other main nutrient of concern. So the reason for that is steroids can affect calcium absorption. So anyone who has been on steroids to treat their condition, we always recommend taking a calcium or vitamin D supplement at the same time. A lot of people with inflammatory bowel disease do avoid dairy products as well. Part of the reason for that is there is a slightly higher incidence of lactose intolerance, especially in Crohn's disease. And lactose is the main sugar found within dairy. So it's found mainly within milk, in a small amount in yogurt, and there's not actually much lactose in cheese. But that's one of the reasons why you may be at high risk of sort of calcium deficiency if you're completely avoiding dairy. The good news is that any dairy-free alternatives, so any of the plant-based milks, as long as they're fortified with calcium, they'll have the same amount of calcium as a standard milk. So if you prefer to have a more plant-based milk, then that's absolutely fine. You just need to make sure you get one that's got added calcium, because they're not always routinely fortified. The other way you can get extra calcium is tinned fish. So it's a really good source of calcium. So tin-boned fish, such as sardines, because the tinning process softens the bones, they're edible, and that's a really high source of calcium. Also, things like sesame seeds can be good for calcium. In a flare-up, as I mentioned, sometimes lactose intolerance can be higher during a flare-up, so it's absolutely fine to change to lactose-free milk or plant-based milk. Just make sure that you go for a calcium-fortified one. And vitamin D, I think, has already been covered, but vitamin D helps with calcium absorption. So we would recommend over the winter months definitely taking a daily vitamin D supplement routine in everyone.
Got a couple of minutes left, Katie.
Oh, okay. So just some general tips during a flare-up, making sure you keep very well hydrated. So that's really important, especially if you were having a lot of frequent loose stools. We recommend aiming for at least 2 litres of fluid a day, trying to limit your intake of caffeine, because that can have a dehydrating effect, and it can also irritate and stimulate the bowel more. Fruit juice, because of the high fructose content, can also have a laxative effect, so we'd recommend keeping that down to a minimum. Trigger foods, I think, had already been mentioned, so probably skip through that. The only other thing which a lot of the patients that I see say really helpful is the frequency of the meals. So eating little and often can be a really good way of managing symptoms during a flare-up. If you are losing weight and you really are struggling, then if it's possible, definitely try and get a referral to a dietitian, because we can prescribe some oral supplements for you, which can really help during a flare-up. They can help manage symptoms and can help prevent weight loss. So that's something that I use a lot in my practice, and the patients really find it beneficial. Have I got time to quickly talk about the food diary?
Yeah.
Okay,
Quickly.
so these are the main reasons why you may want to use a food diary. In my practice, food diaries, we ask for them for new referrals. So we ask patients to fill out a food diary for at least 3 to 4 days, just to get a bit of a baseline background as to what your current dietary intake is. It can be used to see if there are any nutritional deficiencies in the diet, so it can be useful for that. Also, if you are following a new diet plan, such as a low FODMAP diet, or you've been on a liquid diet and we're reintroducing foods back in. So as we were talking before with Isabel, following a food diary when you've been on a liquid diet for that long probably would be really useful to try and assess your tolerance to food as you're reintroducing. And that's just an example template. And this is just taken from the low FODMAP diet. So it's just to give you a sort of guideline as to how you might want to test a food. So we usually recommend building up the portion size quite slowly, so over at least 3 consecutive days. If you are very sensitive to a food, we might actually recommend reintroducing it even more slowly than that. But generally, we would recommend on day 1 having about a quarter to a half a portion. Day 2, you double the portion again, and then by day 3, you want to be getting to what a normal portion would be. If there's any symptoms as you're building the portion size up, we say to stop and leave it for at least 3 days or until your symptoms settle, then go on to the next food challenge. But if you have an extreme intolerance to a food, you may want to do this a lot more slowly. And I think that was a question that had been asked. So that's the sort of basis of what we'd recommend to try and identify food intolerance. I think a lot of this is going to be discussed in Professor Whelan's talk anyway. So the low FODMAP diet I've touched on very briefly, but this is a diet which cuts out short chain carbohydrates, so foods which are highly fermentable and can trigger symptoms in the large bowel. There is evidence for this diet in people with non-active disease. So I just wanted to emphasize it's not a diet we would recommend for someone in a flare-up. It is a diet that we'd recommend if you're in remission, but you're still getting ongoing gut symptoms. So if you're continuing to get loose stools or continuing to get gas or bloating, but we know for sure you definitely don't have active disease, then this diet can be very beneficial, both in ulcerative colitis and Crohn's disease. Stricture management. So as I mentioned before, it's probably the only situation where we definitely recommend limiting too much fibre. And this is a complication of Crohn's disease. So we'd recommend avoiding things like fruit skins, whole nuts, whole seeds, stringy vegetables. Again, texturizing your food, looking at blending using liquidizers. If the stricture is very narrow, then you may need to go on a liquid diet. So we do sometimes use liquid diets in stricturing disease, or if the stricture is inflammatory in nature, so it's not just scar tissue, but if there's actual gut inflammation, then going on a liquid diet can also help manage a stricture. Do you want me to mention the stoma or stop?
I think we probably need to move on.
That's fine.
But I have been asked by the team to say that the slides will be made available to everybody, as well as the recording afterwards. So for the slides that we're not able to cover, everybody will get the opportunity to have them and go through them in their own time.
The only thing I wanted to add is,
Katie,
I know not everyone here has got access to a dietitian. I just wanted to mention that there's a lot of resources available on the BDA website. So I'm just going to go through. So there's some food fact sheets. So I've left the links there. But if you want any extra information about how to increase iron or calcium or folic acid, there's freely available resources on there that you can download. So I just wanted to add that as well. So take-home messages. So yeah, just to summarize, so during remission, the key message really is just don't be scared of fiber. Try and introduce as many foods as you can as tolerated. If you haven't been eating much fiber, then do it slowly. Sometimes what I recommend is you could actually just test one food at a time over 3 days. So just build up really slowly just to make sure you feel confident and it definitely is tolerated. But during a flare-up, again, you can still consume fruit and vegetables. It's just maybe looking at texture modification, maybe thinking outside the box, how can I modify and cook that food so it's a bit easier to digest? Exclusive liquid diets that will be discussed by Professor Whelan, so I don't think I probably need to go into that, but it's definitely good for you to be aware that inactive Crohn's disease, both in children and in adults, it is an evidence-based treatment, and we should be able to offer that to you if you want to follow a liquid diet as an alternative to medication. The only thing I didn't get to talk about at all is complementary supplements, but there's actually very little evidence for complementary supplements except curcumin in ulcerative colitis. But I do obviously have a slide and I've got all the references there if that's something you wanted to look into or explore more.
That's great. Lovely. Thank you, Katie. So much stuff there. I feel like at some point in the future, we will be asking Katie and Shahida possibly to come back and have a webinar to themselves because there's so much content that we can ask, and we can see from the chat that people have got a lot of questions about all of this. So huge thanks to you, Katie, for that. So because we are running slightly over on time, we did say we would have a break, but we've taken the decision that we're going to move on through. We are recording, so if you do need to step away, please do, and then rejoin us or catch up afterwards with the recording. But we're going to go straight in now to our next speaker, who's been waiting ever so patiently. I'm delighted to introduce you all to Kevin. Kevin, welcome. The floor is yours.
Thank you very much, Catherine. What I will do now is I will just share my slide. So my name's Kevin Whelan. I'm a dietitian, and I've spent the last 20 years trying to understand how we can use diet in order to be able to treat and manage life better for people with inflammatory bowel disease. I have a huge job to do tonight. I've got to talk to you about the quality of dietary research. I want to talk to you about exclusive enteral nutrition. Katie and Izzy both talked about that. I want to talk to you about all of these special diets in inflammatory bowel disease that have these really long, complicated names. And I want to talk to you about the evidence that we should be using those or not. Everybody so far has talked a little bit about ultra-processed foods, and I want to show you some of the clinical studies that have been done on that. And I also want to talk about food additives because it's an area we have great interest in. And finally, I want to talk to you about some new dietary guidelines that we've just published. And I've got to do all of that in about 20 minutes. So if you don't mind, I will charge on to my first slide, where I'm going to talk about the importance of research in diet and inflammatory bowel disease. People often think it's not appropriate to discuss how we undertake research with patients. I think it is absolutely central because you are bombarded by messages on media, on social media, from friends, from colleagues, and from your healthcare team. And you need to be in charge of you deciding whether this particular diet has any evidence for it. So I'm going to spend the first 5 minutes talking about how you need to make decisions around the quality of dietary research. There are two reasons why a diet may work for you. A food or a diet may have a physiological effect. And that might mean because that food or that diet has lots of good things in it and less of the bad things in it. And so it might be around fiber or probiotics. A diet might work because of the sugar content, it's low fat, or the type of ultra processed foods there are in it, or whether it's devoid of food additives. So it might work for a physiological reason. But another reason why a food or a diet might work is a placebo effect. And a placebo effect is a really, really powerful thing. And a placebo effect can work in any disorder. And so it might work because your gastroenterologist said that this diet was really good for you, or it might work because the dietitian really listened to your concerns, or you read about it online and somebody was promoting it. It might work because a friend that's got IBD recommended it to you as well. A diet might work because suddenly you have a list of foods to follow and a list of foods to avoid, and now you know what to eat and you finally feel supported. So there are two major reasons why a diet might work: for physiological reasons, like it has an impact on the inflammation in your gut, or because of the placebo effect. And in research, we've got to understand the difference between these. Because in research, we've got to understand if we can prove that the diet works because it has a physiological effect on your inflammation, or whether the bigger effect is due to the placebo effect, i.e., it's due to all of these other reasons that surround it. And really, the only way that we can definitely estimate whether it's working or not is to do a placebo-controlled trial where we compare two diets head on. And what we do in clinical practice and within science is we recognize that not all scientific research is the same. And we recognize using this pyramid approach here that there are some types of evidence at the bottom which are not as strong. And that's just using personal experience or opinion. So if somebody else says that they've tried something online, then that's the lowest form of evidence. What we can do, and Dr. Din referred to this in her presentation, she talked about observational studies. These are where what you do is you look at a small group of people or sometimes hundreds of thousands of people who are healthy, and you watch them over time, and you watch whether they get IBD or they don't get IBD. You determine whether certain foods or certain diets are related with getting inflammatory bowel disease or not. But then finally, and the sort of evidence we need to be relying on most, and unfortunately there's very little type of research like this in inflammatory bowel disease, we want intervention studies. Here's where you take lots of people with inflammatory bowel disease and you give some of them a special diet, and then you give some of them a placebo type diet, and then you measure how that works. And that's really the only one that can control for this placebo effect. So what I'm going to do for the rest of this presentation is, when I'm talking about specific diets, I'm going to tell you the type of evidence that's been used. And what you need to be looking out for is, ideally, we should be looking at the intervention studies at the top and not the experience and opinion at the bottom. And the first thing that everybody tonight has referred to is this exclusive enteral nutrition in Crohn's disease. So exclusive enteral nutrition is when Izzy was talking about it. She was talking about how you have these drinks and you cut out all foods and you just rely on drinking these drinks as a sole source of nutrition for 6 weeks, sometimes much longer. And what we know from intervention studies, so the highest level of evidence, we know that these are effective in particularly in children. So when you compare exclusive enteral nutrition, 83% of children will go into remission, compared to only 61% of people taking corticosteroids. So we know it's highly effective. A little bit less effective in adults, and we think the reason for that is because it's more difficult for adults to cut out eating and drinking from their lives and to rely on drinking these drinks. So again, both Izzy and Katie talked about the importance of having a dietitian to support you through this type of therapy, and it's absolutely essential you do have a dietitian to support you here. But again, it's highly effective in adults. It's just not quite as effective as drugs because it's difficult to adhere to. So one thing I wanted to mention was whether we can, whether there's evidence for trying to do exclusive enteral nutrition, but by trying to avoid some of the problems of tolerating these drinks. And so one thing you can do is one approach that's been tried is to try to reduce the volume of these drinks that are required. And an approach to this is the Crohn's disease exclusion diet. I'm going to talk about that. And another approach is to try to replace exclusive enteral nutrition, this drink-based diet. So can we recreate these drinks through using diet? So and that's called the CD treat approach. I'm first going to talk about the Crohn's disease exclusion diet. This is the Crohn's disease exclusion diet here. This is a diet that avoids a variety of different things. There's a long list of things there: avoiding gluten, avoiding dairy products, animal fats, processed meats, emulsifiers, baked goods, canned foods, and packaged foods. They also recommend that you eat specific foods that are mandatory during this period of time. So chicken, fish, eggs, banana, and apple during this time. This was designed in Israel and has been adopted quite widely and trialed in a number of very small clinical trials. Here's the biggest one that's been done to date, and this was done in children with Crohn's disease. And what they did is they compared this exclusive enteral nutrition, so taking this drink-based approach versus having half the amount of these drinks and being allowed to eat some normal foods, these foods from the Crohn's disease exclusion diet. And what they did in this clinical trial here, published back in 2019 now, is they compared these two approaches in 78 children who had active Crohn's disease. What they showed is that children were much more likely to be able to complete a course of partial enteral nutrition combined with this special diet. Of course they were. Of course that was possible because eating food is better than not being able to eat any food. But there were no differences in any of the other clinical outcomes. So, i.e., it was shown to be as effective. So having the Crohn's disease exclusion diet in addition to partial enteral nutrition was as effective as having the drinks as the sole source of nutrition. So really, really promising news. Since that time, what's the research in adults? Since that time, the same group have conducted a clinical trial where they've compared 40 adults with active Crohn's disease, and they've compared having Crohn's disease exclusion diet in addition to partial enteral nutrition compared to Crohn's disease exclusion diet alone. So the highest form of evidence that I talked about again. And again, they've shown really, really promising results in that there was no difference between the two diets. The problem is this is quite a small study, so we can't rely on this at this stage. So we need much bigger trials of the Crohn's disease exclusion diet. But what I can say with good confidence is the Crohn's disease exclusion diet combined with partial enteral nutrition is as effective as exclusive enteral nutrition. So that's the first promise that we might be able to reduce intakes like that. The second approach I talked about is replacing exclusive enteral nutrition, and this is work done up in the University of Glasgow. That's a photo of the colleague leading that, Professor Gerasimidis. And what he's done is he's designed a diet that excludes gluten, it excludes lactose, it excludes alcohol, it restricts a little bit the starches and the fiber in the diet. but it's similar to exclusive enteral nutrition in terms of macronutrients and micronutrients. And what he's done is he's done a very, very small trial, so just experience in 5 children with what he calls the CD treat diet. And what he was able to show in 5 children following this special diet is that they were able to reduce their disease index. That's the figure at the top. You can see that after 4 weeks and 8 weeks, the disease indices reduced, but also fecal calprotectin. That is a marker of inflammation in the gut. You can see that also in those 5 children, the inflammation also went down in those 5 children when following this special diet. And what Professor Yeromsimidis is doing right now is he's doing some clinical trials, so the top of the level of evidence for that he's conducting those to see if they work now. Okay, you may have heard of the specific carbohydrate diet. This excludes grains, it excludes sugars, milk products, but includes a variety of different foods. Until recently, the only evidence for this was experience and opinion, but I'm pleased to say that recently there was a clinical trial published in 191 adults who had mild to moderately active Crohn's disease, and they compared the specific carbohydrate diet with the Mediterranean diet for 12 weeks. So it's really great that we're now getting big trials of studies. What that showed is that the specific carbohydrate had 43% of people felt better on the specific carbohydrate diet compared to 46% of people on the Mediterranean diet. So put simply, there was no benefit of the specific carbohydrate diet, which is a highly restrictive diet, compared to following a healthy Mediterranean diet that Katie just described in really, really good detail. So actually, we don't think that the specific carbohydrate diet is any better than following the Mediterranean diet, which is a much healthier diet for people to follow. I said I would now talk about ultra-processed foods. This has been mentioned by Dr. Din, by Katie in her presentation as well. What we know is that in the UK, about 56% of the energy that we eat in our diet comes from ultra-processed foods. So we eat a huge amount of ultra-processed foods in our diet. Now, I'm just reminding you, this is evidence from observational studies. So this is evidence of watching people, healthy people over time, measuring what they eat and measuring whether they develop inflammatory bowel disease. And what these studies show is that overall, people who consume high levels of ultra-processed foods have a 71% higher risk of developing Crohn's disease. But we think that so far that there's no association between ultra-processed food intake and the development of ulcerative colitis. So 71% higher risk, so that's in people who are healthy and don't have Crohn's disease, there's a 71% higher risk of developing Crohn's disease. I want to put that in context for you because that sounds like a really scary statistic. Here's a town of 10,000 people, and within the next year, we know that within the next year, 1 person in that town would develop Crohn's disease because of the statistical. We understand how many people will have risk of developing Crohn's disease. So in the next year, 1 person in that town of 10,000 people would develop Crohn's disease. So what that means is if suddenly loads of people in that town started eating lots of ultra-processed foods, we know that 1.71 people would now develop Crohn's disease. So I just wanted to put that in context because I know it can sound like a 71% increase can sound very scary, but because the rate is very small, it maybe doesn't sound as bad as you think. One of the reasons we are concerned about ultra-processed foods is because of food additives. This is what healthy gut looks like. Here's a figure from a paper that we published recently showing a healthy microbiome, a nice thick mucus layer in the gut, healthy cells underlying that, and a healthy immune system underlying that. And what's been shown is that when you particularly emulsifiers in particular are added to that. They can change the microbiome. They can reduce the thickness of the mucus that protects the cells underneath. The cells, rather than being healthy and impermeable, they can become inflamed. You can see those cells are now red. They can become inflamed. They can become leaky and cause a leaky gut and start to cause inflammation in the underlying immune system. And we know, of course, that that might lead on to inflammatory bowel disease. So we've just completed something called the ADAPT clinical trial. This is with lots of amazing colleagues mentioned on this trial. Some of you listening, I'm sure, have heard about the ADAPT trial. And if some of you took part in this ADAPT clinical trial, thank you very much for taking part. We are eternally grateful for the help you've given us in teaching us how to better treat inflammatory bowel disease. This was the ADAPT trial. So what we've just done is we've taken 140 people with Crohn's disease, with active Crohn's disease, and we've given them either an emulsifier containing diet or a low emulsifier diet. And we did that through regular dietetic consultations, through giving them an app with a bar scanning function, which told them whether they could eat the food or not eat the food. And then we supplied them with some supermarket foods and some snacks, and either the snacks did contain emulsifiers or they didn't contain emulsifiers. So we did this as a proper placebo-controlled trial, so the highest level of that accuracy. And so, for example, some of these products here, some of these cereals, mayonnaises and peanut butters contain emulsifiers and some don't. And I bet you can't guess which ones do. And here are the ones that are emulsifier free. And there are examples there of one that contain emulsifiers. And I bet now, during our clinical trial, it would be even more difficult to tell which do and don't contain them. And here are examples of the sorts of snacks we gave people. And here are the answers. What we found, thank you for contributing to this evidence, those people who have, but what we found was that people who were following a low emulsifier diet, about 49.5%, about 50% of people got better, and compared to people in the control group, where only 30% of people got better. What we know is that if you statistically take into account all of the other factors, people following a low emulsifier diet were 3.1 times more likely to respond when, i.e. for their symptoms to reduce, when they were following a low emulsifier diet. And it's not just symptoms, it was also 2.1 times as many people were likely to go into remission of their Crohn's disease. They were more likely to have a greater reduction in their Crohn's disease score, and 2.9% were likely to have a significant reduction in their fecal calprotectin, this marker of inflammation. So we're really excited. We haven't even published these results, but I really wanted to bring these results to you to present them back to the community who helped us to be able to produce them. Finally, in the last 1 minute, I'm just going to mention these important guidelines that have been published. I was lucky enough to be part of the latest European guidelines for the management of dietary management of inflammatory bowel disease. And what we did is we all worked together alongside people all across the world, experts from gastroenterology, from dietetics, and also patients with inflammatory bowel disease. And we worked in working groups to make different dietary guidelines. We got 48 dietary guidelines in those important areas. And the first important thing is that really the thing that we should be recommending to patients is that as much as possible, they should be following healthy eating guidelines as much as possible. Exactly the sort of thing that Katie was talking about earlier. And the second thing that we recommended is that all people with IBD should have access to a dietitian with experience in IBD. And I know that many of you do not have this. And what we want to do is for these guidelines to change that. As part of the NICE clinical quality standards, we recommend that every IBD service should have access to a dietitian specializing in gastroenterology. And we know that you don't. And so we hope hope with guidelines like this that you will be able to overcome that. Okay, so here are my take-home messages. We don't know exactly what the best diet is. We know that exclusive enteral nutrition, these drinks work. We know that the Crohn's disease exclusion diet and the low emulsifier diet have the best scientific evidence so far. So the specific carbohydrate may work in Crohn's disease, but only as well as the Mediterranean diet. But the Mediterranean diet is much more healthy for you than a restrictive diet. So we'd rather you followed something like the Mediterranean diet. We know that some people with IBD respond more and some respond differently to diet than others. That's just normal, and I'm sure it will be the lived experience of lots of people on this call. If you're interested in following a special diet, you must do that in conjunction with your clinical team and with the support of a dietitian if you can access them. Now, I have talked about how little evidence there is to support diet, but that doesn't mean that diet is important. It means we have failed, and we need to be doing much more research on diet and inflammatory bowel disease. And you know what? We need to be doing much more research on diet and ulcerative colitis, because so far most of the evidence is in Crohn's disease, and we need to overcome that rapidly. Thank you very much for listening, and we're excited to have the panel discussion.
Kevin, thank you. Again, lots of evidence from everybody watching about how interesting and how useful people found that, and loads of comments and questions. So thank you for your time. You waited really patiently behind the scenes for us, but that was brilliant. Thank you. So I'm going to invite Katie and Shahida back to join us. Now, we do have lots of questions, and we are acutely aware that we are running over. So I'm going to be a fierce chair for the questions and try and keep us to nice, short, sharp answers where possible, if we can. So first up, question one. We had lots and lots of questions today about why IBD can feel like a bit of a lottery, and why certain foods can affect you really badly one day and be fine on another day. So Shahida, I'll start with you. Why do you think this is?
Thank you. That's a really good question. I think I maybe hinted at it in my presentation, is that IBD is very individual. There's so many different changes from a lifestyle perspective, from the environment that people live in, that actually can result in inflammatory bowel disease. And for Crohn's disease, it's such a different disease for everybody, and it affects different parts of the gut. And we often find that it is very individual. For Crohn's disease, for ulcerative colitis, less so, because the large bowel is mainly affected. So I think it just demonstrates how different the disease is for everybody. And we think that maybe relates to, as I said, genetic changes, the environment, the microbiome. We're not really at a position yet to be able to try and help us understand that. And I think Kevin's right, is that, we are so grateful for people who are involved in studies to help try and, give us some information, in that you might not be able to, so no two people will be the same. I don't think we'll ever find that two people will ever be the same, but you will find common patterns within their disease or in their lifestyle that you might be able to then help influence with the treatments that we have. So yeah, I'm not sure that's a perfect answer, but it's the best I can give at the minute.
It was a mean first question, I think. So following on from that, and this is one perhaps for Shahida and Kevin, so I'll leave it up to you to divide up who takes it. So is an exclusion diet the best way to discover foods that you might have an intolerance for, or are there specific tests that you can do to discover your triggers?
Shahida, shall I take the first part of that? Firstly, I know that online you can go online and you can buy all sorts of tests to measure your IgG, your IgE, and things like that. In general, we do not believe it is necessary to do that in inflammatory bowel disease. Katie showed this great example of how you can do that using a food diary and then slowly introducing things into your diet. My personal belief is that you should do that in conjunction with your medical team and a dietitian at your hospital, though. So rather than doing it in the wilderness on your own, but I do also understand that you don't all have access to that.
And just while we're on that then, so we did have lots of questions come through, lots of comments in the chat about access to a dietitian, and people were sort of asking, where do I get one of these and what do I do if I don't have access? So that is not a question that we can answer for everybody here, but could somebody perhaps just explain for us what you should get and what perhaps people can ask for to check if that's available in their area?
Okay, so if you don't mind, I'll take the first part of this again. But it is not right that people with IBD don't have access to a dietitian. So, like I said, the NICE clinical standards state that an IBD service should have access to a dietitian, and the latest ECHO guidelines say that all IBD patients should have access to a dietitian. We know that's not being ruled out. The NHS is not flooded with money. We also understand that, but we are trying to change things. So please ask if there is one available of your IBD specialist doctor. Ask if there is one available. We know that in many services, there might not be one in the room next door. You might have to wait for an appointment. In an ideal situation in Katie's service and Shahida's service, we know that you'll be able to access them much quicker, but we know it's far from ideal. But I'll hand over to Katie and Shahida to maybe comment further on that.
I don't know if you want to say anything about that, but yeah, I mean, it is difficult, really. I mean, obviously, we're lucky where I work that, you know, they have funded an IBD dietitian, but we're still extremely stretched. I think most services are. I mean, if you could find out if there was maybe another trust, you know, if your local trust doesn't have a dietitian available, could you maybe speak with your GP? And they may be able to access a dietitian elsewhere. Not that I'm endorsing necessarily private practice, but on the BDA website, you know, there will be availability to get dietetic help there. The resources I've also put on my slides. So there's a lot of free resources available through the BDA website. We also have information through the National Dietary Resources as well. Some of them you do have to pay for, but your healthcare professional would be able to access those resources for you as well, to give you a bit more information on the Crohn's and Colitis UK website as well. There's a really good dietary resource on there.
Brilliant, thank you. Okay, so moving us on. Can a good diet put IBD into remission without the need for medication? Who's up for that one?
There's another one for Kevin to maybe
Kevin,
answer.
it's a Kevin question.
Yeah, I think I hope I answered that during my presentation. Yes, it can. So, for example, the low emulsifier diet we talked about. I talked about our trial. The problem is that's absolutely brand new. We haven't even published it yet. We're going to need to train dietitians to be able to give that advice. We're going to need to produce resources to support patients to do it. There's a long way to go for that. So, but please be patient. I promise we're working really, really hard on that. The Crohn's disease exclusion diet, yes, I believe that's ready for application. I know lots of you have benefited from that, so that can help. And loads of other approaches, you know, the sorts of things that Katie talked around maintaining a healthful diet with something like the Mediterranean diet. So yes, it can, but that doesn't mean, so if your gastroenterologist is recommending you take a medication, you should take a medication. You should follow that medical advice. You know, it shouldn't be seen as alternative. It should be seen as complementary.
Great. Brilliant. Thank you, Kevin. So Shahida, one for you now. How long after you eat the wrong food will it affect you? And how long before the effects stop?
Again, that's a good question. I think maybe to benchmark how we might answer that is that when you eat food, your stomach a normal stomach will take up to 2 hours to empty that food. A normal small bowel, the food will take about 6 hours to get through it. And if a normal colon can take anything between 1 to 3 days, and that obviously then reflects how often people go to the toilet. When you have inflammatory bowel disease, all of those processes are slowed down. And so again, it will depend on how much of your bowel or gut is affected. It will depend on the composition of the food that you eat. Some foods are more easily digestible, for example, simple carbohydrates, which is what we often ask you to do when you have a flare and avoid lots of fibre. But equally, protein and fats do take a little bit longer to digest as well. So it really does depend on a number of different factors. There's no easy answer here. I often ask patients actually to tell me actually, because they will often say to me, you know, I had this for breakfast and I still feel it sitting in my stomach. So I find that patients are a really good barometer for their own symptoms, and they will guide me and they'll tell me what things are good for them or what they feel they can comfortably manage and what things that they have to avoid from a food perspective.
Yeah, thanks, Shahida. So, Katie, one for you now. I think we had a lot of questions come in around the question of fatigue. So, people saying they feel permanently exhausted despite eating well and taking iron and B12 supplements. So, they want to know really, is there anything else they can do to try and relieve some of those symptoms?
I suppose the first thing will be to find out there's definitely no underlying inflammation. So those ongoing fatigue symptoms are related to maybe that they could still be in a flare-up or have a low-level flare-up. So usually what I would recommend is getting a stool test. So I'm not sure if it was mentioned earlier, but you can get a stool fecal calprotectin, which can determine whether you are actually having underlying gut inflammation. So that's one thing I'd recommend. The other thing I didn't really get to talk too much about the supplements on my slide, but it can be very beneficial to also take a complete multivitamin and mineral. We can get some really good ones on prescription as well, like Forceval. But you could get some really good ones over the counter, like Sanatogen or Centrum, which are really good and complete. So taking one of those could be beneficial. In my patient group, sometimes the fatigue can be linked to ongoing gut symptoms. So I use a lot of enteral nutrition or oral nutritional drinks, which can be a bit easier to digest than solid food. So some people actually find it improves their energy levels by having some form of nutrition as liquid oral nutritional supplement drinks. And they also are fortified with vitamins and minerals as well, so they may help boost energy levels. So I suppose it's establishing the reason or trying to establish the reason behind the fatigue. But there's some of the things that I found useful in my practice.
Brilliant. Thanks, Katie. Kevin, we had quite a few questions come in about constipation from people using laxatives without any success or dealing with solid plugs of stool alongside diarrhea. So have you got any top tips on combating constipation? And that's harder to say than you think at 9 o'clock, nearly at night.
Combating constipation, right?
Yeah, that's the one.
So that is a great question. We get so used to associating diarrhea with inflammatory bowel disease, but I know a lot of people with IBD also can suffer from constipation. And there are 75 different clinical trials, so the highest level of evidence where you put some people into one group and put people into another, of using nutrition or diet to treat constipation. None of those trials are in people with inflammatory bowel disease. There is not a single dietary trial of how you treat constipation and inflammatory bowel disease. So all we can rely on is the evidence from the general scientific evidence around managing constipation. Earlier this week, we just published the national guidelines for how you use diet to treat constipation. And here are some top tips. Supplements of psyllium fiber. So psyllium, so that's available in your health food stores or on prescription called fiber gel. That's very effective at managing constipation, and also isn't very fermented, so shouldn't cause you bloating. There are some clinical trials of prunes, of kiwi fruit that have also shown to be beneficial. Some probiotics have shown to be beneficial in constipation, and in general, high fiber diets haven't been trialed in many studies, but high fiber foods have been trialed. So things like rye bread and things like that. Be careful, some of them may cause lots of fermentation and bloating and things like that. So do be careful if you're trying to manage this on your own.
And I really don't want to put you on the spot, but I'm pretty sure psyllium starts with a P, doesn't it? Because everyone's gone to Google that right now. How do you spell psyllium?
That is a great question. You're absolutely right. It's a silent P. So it's P-S-Y. Oh gosh, I'm writing in the air right now. P-S-Y-L-L-I-U-M.
Perfect. There you go. So for everyone who was Googling it, that's how you spell it. Brilliant. And then what about gas and bloating? So any dietary changes that can be made to help with those symptoms? That one's for Kevin, I think, again.
Great. Okay. So Katie touched on this, and so what we know is that there are certain types of carbohydrates that do things to the gut. They do them to absolutely everybody, not just people with IBD. They do it to everybody on this call. So, and what they do is they have a laxative effect. Some of these carbohydrates can increase the amount of water in the gut, and some of them, when they get to the big part of the gut, they get fermented by all the bacteria and they produce loads of gas. If you have a sensitive gut, like some people with IBD do, we know that about a third of people with IBD, even when they have no inflammation, will still be getting abdominal pain and diarrhea. And we know that removing these carbohydrates from the diet can improve their symptoms. And that's called a low FODMAP diet. That's what Katie talked about earlier. We did a clinical trial and we showed half of people who were following this special diet had no symptoms at the end of following that. People with IBD must never follow the low FODMAP diet unsupervised without the help of a dietitian, because it is very, very restrictive. So I'd really recommend, if you know you're in remission, but you're still having symptoms of bloating and abdominal pain, it is something you consider a low FODMAP diet, but do it under the supervision of a dietitian.
Brilliant. Thanks, Kevin. Katie, couple for you now. So some people have spoken about managing their symptoms through not eating. So for instance, they wouldn't eat before they go to work or perhaps during the day at work. What guidance and advice would you give them?
I think in that situation, I'd probably want to just run through their diet, find out what they were eating before previously breakfast, see if there's any maybe more easily digestible fibers that we could adapt the diet to. I do in my practice use a lot of partial liquid diets as well to help with symptom control. So for people who really aren't able to eat any solid food in the morning, sometimes taking a nutritional supplement drink in the morning can be beneficial because they're still getting all the energy and nutrients, but it's in a much more easily digestible form. So that's one way of getting around it and hopefully helping people who potentially will be at risk of losing weight and, you know, get malnutrition if they're repeatedly skipping meals. So that's one of the ways that, you know, would help them to manage it. But filling out a food diary in that situation might be useful as well to try and establish potential triggers if they, you know, would like to look at other ways of more easily digestible foods when their symptoms are worse.
Great, thank you. And we've also had, Katie, a few questions from parents of teenagers looking for help. I mean, I could just leave it there as a parent of teenagers, but there is a question looking for help with supporting them to manage their condition and take ownership of it, and reduce their anxiety around food. Have you got any tips for those people?
I mean, it is a very challenging time having this condition as a teenager, at the time when you're getting a bit more freedom, maybe going out with friends. I think I mentioned this earlier when I was speaking to one of your colleagues. In my experience, the parents also share quite a lot of that anxiety because once you get into the teenage years, they don't have full control anymore over, you know, their child's diet. So it could be like a shared anxiety between, you know, the parent and the child. I suppose it's just, again, going through education. So educating them about healthy eating, educating them about the rationale of why we recommend these specific diets, how it's going to affect their gut. You know, it is okay to have the odd treat now and then, as Isabella said. You know, if they wanted to go out and occasionally have you know, fizzy drink or a cake, I think on occasion, hopefully Kevin will agree, it's okay on the occasion. It's just these are the types of things we're really just recommending keeping to a minimum. So I think just reassuring that it's getting the right balance, but nothing is completely to be avoided. And trying to educate both the parent and the child, because I think it can be a shared difficult experience really when you're diagnosed at that age.
Really helpful. Thank you, Katie. We are aware that we have run over, but we've got lots of people stayed with us. So I'm going to keep going if that's all right with the panel, just for us to plough on because people are sticking with us. So Kevin, one for you. What advice would you give to someone very recently diagnosed with IBD in terms of eating out in restaurants and sort of managing that anxiety about going out for meals?
Yeah, great question. We've done lots of work where we've interviewed people with IBD, and this is really, really common. Eating out becomes a real trigger point, if you like, of hang on, I'm not in control of what I'm being served. So what's really, really important is that you do go out to those restaurants. You know, you must not stay at home and never eat out. You must try to make food a positive part of your life, because you don't just eat out at a restaurant. You chat with friends, you chat with your loved ones. You might be going on a date with someone, or you might be going out with colleagues from work. So you must try to develop approaches that can allow you to be able to do that. We've done work where we've developed resources to encourage people to, if you know you're going to a certain restaurant and you're worried about what you might be able to eat, check the menu online. So go check the menu online, check what they have, and so you can see in advance. If there's something on there that you think, oh, I quite like that, but I don't know whether they cook it with this or with that, give them a call and ask them. We also know that people don't always like asking those questions in front of their friends from work, because then they might have to disclose they have IBD, and they might want to not want to tell somebody, well, I've got ulcerative colitis, and you might not want to tell your colleagues at work that. So call up the restaurant beforehand and ask them those questions in privacy, so you can have a conversation about how they cook that beforehand. And there are ways of managing, but do make sure that you don't not eat out, because it is an important part of social function.
Definitely. There's more to it, isn't it, than just the food?
Yeah,
Some
that's right.
great advice. Shahida, is there any evidence for the keto diet or the carnivore diet?
Yeah,
Lots of
probably
questions about keto.
Kevin and Katie should probably take this one, but
Oh, okay.
it's just interesting that there are different diets that people try, don't they, to keep healthy and to keep themselves well. And with a keto diet, it's got a lot of protein and meat in it. And I guess one of the things we are asking people to think about is how much meat you are eating and the types of meat that you are eating. And so I'm not sure that some of these diets would then fit in with the healthy eating patterns that we try and promote. And I find that a lot of patients with inflammatory bowel disease follow actually quite a restrictive diet anyway. When you actually start asking people what they do, and as Kevin says, they don't go out to restaurants. And I love that tip of phoning up beforehand, actually. That's such an amazing thing, actually, which I'm now going to tell everybody to do. Just phone up, because honestly, businesses really want your business. They want you to come, and they're very willing to modify what they do. And I'm just, as a disclosure, two of my children have a dairy allergy, so I will often do that. But it's just never occurred to me that I should ask my patients to do that too, from that perspective. Is just go and ask. So I think if you do want to follow a particular diet, just as we've said all through this webinar, is that please touch base with your GI team, even if they don't offer you a specialist dietitian at the time. Please just touch base with them, to make sure that it is still going to provide you with the nutrients that you need, and then you can take that further forward.
Lovely, thank you. And Kevin, is there any evidence for the benefits of intermittent fasting? We hear a lot about intermittent fasting for all manner of management of symptoms and weight loss, but is there any evidence in terms of IBD?
That's right. So intermittent fasting, we hear lots about it, don't we? Irrespective of IBD, nothing to do with IBD, but we just hear a lot about it. So intermittent fasting, for those on the webinar who might not have heard of it, it's either where you restrict your eating to certain hours of the day. So maybe you only eat in an 8-hour window and you fast for the other 16 hours. Or it's where over a week you might eat normally for 5 days and you might really restrict dietary intake for 2 days. So there are different ways of doing it. The reason people are getting interested in this in IBD is because there's some evidence from animal studies that intermittent fasting might be good for inflammation, but it's never properly been trialed in people with IBD. The only evidence we have is from people who are Muslim and going through Ramadan and fasting through that, so fasting during daylight hours. And we suspect it's not harmful, but the study didn't show it was any good in treating IBD. And the only other study that's been done is that some people who had IBD and were also overweight, what it showed was that intermittent fasting, as has been shown in people without IBD, helps people to lose weight, and it didn't harm their IBD. So we think it's useful for losing weight, which in itself might be good if you are overweight or you have obesity and you have IBD. But we don't think it's really treating the IBD. We just think it's helping with overweight and obesity.
Great, thank you. And sticking with weight loss, weight maintenance. So we know that that can be an issue with people struggling to either keep or gain weight with IBD. But we've also had quite a few questions about weight loss, with people wanting to know the panel's thoughts on things like meal replacement diets and GLP-1 weight loss injections, such as Mounjaro.
So
who's going to take that one?
I can take that one.
Go for it.
So I guess meal replacement diets are essentially, I guess, a type of treatment for IBD that we use. You know, the exclusive enteral nutrition or the polymeric diets are a form of IBD treatment under specialized care, and obviously not the same weight loss supplements that you might buy over the counter. So that is, you know, we do that already as part of treatment. And I think as long as patients can tolerate the supplements, my own personal feeling is that that is okay. Because obviously, you know, wanting to lose weight and be healthy is part of their overall goal of looking after themselves with inflammatory bowel disease. Be interested to know what Kevin and Katie think on that aspect, whether we'd say anything differently. No, not really. Okay, good. And I think that, you know, it's about supporting people, isn't it? Is that first and foremost, there's people who do have this condition, and we have to look after them as a whole. So interestingly, there's lots and lots of information now, obviously, about the weight loss drugs that are being used, Mounjaro or the other ones that are prescribed. And again, they are very useful for weight loss. There is, from an IBD perspective, I guess, the way they work is that they actually slow down your digestion. So we know that. So patients who have tried it and have come to meet me in clinic have said to me that they feel full. It seems to suppress appetite. And sometimes that might make your IBD symptoms worse. So, the symptoms that you get might make you feel like you've got a flare of your symptoms. Is what I mean, is that they might feel uncomfortable and bloated, and they might get more wind, and it might be difficult for them to just the digestion to go through, more quickly. So there will be knock-on effects. There is some interest as to whether these new weight loss injections that are being provided may have an effect on inflammatory bowel disease, and we are hopefully going to see in the UK, specifically, maybe over the next 1 or 2 years, a number of different trials that might be used along with IBD treatment medications. And so I think if patients are interested in that, and obviously this would only be eligible for patients who are overweight. It wouldn't be for people who are, normal weight or underweight. This would only be eligible for people if you're overweight or obese and you were keen to be involved in the trial that would give you some of these treatments alongside your standard treatment for your IBD. Yeah, so there is some interest. There is some interest, and so we are.
There's anecdotal, isn't there? When you talk to people, there you can tell that this is an area that people are interested in because they think there might be a link. Okay, we've got 2 questions, and I'm going to see if I can squeeze them in. One, really important because we always get asked about microscopic colitis, and it doesn't ever feature as the main event in any of our webinars, but we always do like to cover the questions. So is there any specific guidance for microscopic colitis that might differ from Crohn's or ulcerative colitis? And that one's for you, Shahida.
Yeah, so absolutely. Microscopic colitis, we believe, is also an inflammatory bowel disease, and not everybody agrees with that. So it's interesting, even across the UK and the world, not everybody believes that microscopic colitis is a form of IBD. There are specific dietary approaches to actually help manage symptoms of microscopic colitis that do suggest some benefit. And those are mainly looking at whether you exclude dairy in the diet or gluten in the diet, and sometimes things like caffeine and alcohol that can make gut symptoms worse. Again, if you are going to think about these or you are being offered these by your medical team, and I would hope that they would do that in conjunction with a dietitian, because again, if you're starting to exclude big food groups from your diet, you want to make sure that your diet is nutritionally complete from other sources. And I like Katie's suggestion that, multivitamins that are complete are a useful adjunct for patients who are worried about their overall intake. So that's the information that we have for microscopic colitis so far.
Brilliant, thank you. Okay, and I wanted to end on a positive question. So this one's for all of you. We've had a question from someone who says they've tried really hard not to make it feel like food is an enemy. That's what they want to try and overcome. So we want some tips, please, on how to think positively about food again.
Catherine, if I could just start there, it makes me so sad to think of people seeing food as an enemy, and I totally understand that why that would be the case, and it's why I've spent years trying to investigate this. Food should be a pleasure in your life. Can I give 2 tips? Firstly, Izzy talked earlier about how there were some things that when she was in relapse, when she was having a flare, and she'd eat them and they'd cause really bad symptoms. But actually, when she tried them when she was in remission, they were okay. So don't assume that just because it was bad then, it will always be bad. So do retry things. And the other thing Izzy said, it really impacted on me. She said, whenever I think of excluding something, I always think how I can add something else in as well. So like, broccoli was okay for me, so now I've tried purple sprouting broccoli. If you go in with that sort of attitude and you're like, right, I'm not going to let this disease run my diet, I'm going to run it, and do that thing that what Izzy said really impacted me. So try to always introduce something if you're thinking of taking something away.
That's a great tip. Anything else to add, Katie?
I think I would just reiterate that, really. Just don't be afraid, or, you know, even if you've had a symptom once, it doesn't mean that you're going to have a symptom next time you try it. There's lots of other variables as well. As Izzy actually mentioned, stress, you know, other factors in your life can actually make your gut more sensitive. So it's always a good idea to retest things. Also, maybe testing things at a smaller level. So doing it really, really slowly and cautiously, that will hopefully help you to build your confidence with increasing, you know, more of a variety of foods in your diet. It may just be that you can't quite manage as much as you would like of that food, but hopefully over time you'll be able to increase the variety of different foods by using like a cautious, slow reintroduction approach.
Another top tip. Thank you, Katie. Anything from you, Shahida?
I was just going to ask that I've learned so much just from listening to Kevin and Katie today, honestly. I think there's, I was so pleased when I heard that you were doing this webinar and then you asked us all to come on, because I think there's just so much misinformation about diet. And part of that is our fault too as healthcare professionals. We haven't given consistent advice over the years because the advice hasn't been clear for us either to interpret. But as we're getting better, and we're understanding it better, and all the work that Kevin and other people do in that area, it's so important for the research to actually happen, to be able to give people more clear answers.
Yeah, well, thank you to all three of you and to Izzy for joining us this evening and sharing your expertise and your stories. It's clear, and we will share the feedback with you. It's clear from the feedback we're getting how valuable people have found this. So on behalf of everybody watching, just a huge thank you to Kevin, to Katie, to Shahida and to Izzy. Thank you to everybody for joining us as well. Hopefully people can still stay on for just a couple more minutes because I just want to say a few words about the ways in which Crohn's and Colitis UK can help you. Okay, so we have a wealth of information available on our website covering the topics that we've talked about this evening and so much more besides. We've talked about the importance of using trusted sources, and I'm proud to say that all of our health information is PIF-TIC certified. So this means that the Patient Information Forum, who are an independent body, have rigorously assessed us and agreed that our information is produced to the highest possible standard. You can trust it. And we work with patients and clinicians to make sure all of our evidence is evidence-based, up-to-date, trustworthy, clear, and easy to understand. So if you want to know something, head to the link that's on the slide and have a look at what information we have available. So in particular, one of those resources is our resource on food, which you can see the link to there. You can read that online or you can download it and print it if that works better for you. We also know that Crohn's and colitis can feel really isolating and that it can be really valuable to talk to other people who just understand what you're going through. So we run regular online sessions called our virtual social events, bringing people together to share their experience and tips, to give and receive support. They're informal events and you can talk as much as you want or as little as you want. And they're run by people who have lived experience of Crohn's and colitis. So if you're interested in that, the link is currently on the screen. You can also learn from other people's experiences and share your own on our private Facebook forum. We have 85,000 members and it's a great place to go and get peer support and connect with the Crohn's and colitis community. And last but by no means least, we have our helpline. So our helpline are there to listen, to talk you through your situation, give you information about Crohn's and colitis, and help you find further support. Please bear in mind that they're not able to give you individualized medical advice. You can speak to us over the phone, by email, or online on live chat. 99% of the people who use this service tell us that our helpline said that they would recommend, our helpline to other people. So if you want to give it a go, if you haven't found it already, please do. We'll be open from 9 o'clock tomorrow morning. If the helpline is closed when you call, please leave a message and we will get back to you. So that brings us to the end. Please do, if you can spare us another couple of minutes of your time, please give us some feedback in the link that you'll be connected to. We really do want to be able to make these events as useful as possible. And so every bit of feedback about what worked well, what didn't go quite so well, and what we could do in the future to make sure that we're providing you with the support that you need, please tell us. And thank you. Thank you once again for joining us. Thank you to all of our wonderful speakers. Thank you to the staff who are behind the scenes making this happen. And good luck, everybody, with navigating your Crohn's and colitis diagnosis through the world of food and diet. And hopefully we've all learned something this evening that will help. Take care, everybody.